What about sleep? This is something that's come out of Jim Lloyd's group and Lisa Lancaster. So there's long-standing literature that patients with, first of all, lung disease in general don't do as well with sleep. You see, when we sleep, we should have enough lung reserve that we maintain our oxygen levels. But if you have diseased lungs, no matter what the disease is, the likelihood of having desaturation goes up. And any daytime oxygen requirement gets increased at night. But there's little overall data until recently. This was an old slide I threw in there. This Memgurka study only looked at 18 patients and showed a fairly high rate of snoring. And there was a second study that followed that looked at sleep disturbances that didn't really tie to the polysomnogram. That is, that patients can have atypical sleep disturbances that we don't usually think of in sleep apnea. And I really like this study that basically took a look at the level of desaturation in these patients. So if you take a look at patients with daytime O2 sats greater than 93%, 33% of them are still going to have desaturation at night, meaning you can't use the daytime saturation to predict. If they desaturate, it goes up to 89%. So we know that if they desaturate during the day, you're going to catch it. And if they desaturate with walking, you can see 41% had a desaturation at night. Sorry, if they didn't desaturate with walking, you still had 41%. And if they did desaturate with walking, you had 45%. So you can see that it's not just about apneas or hypopneas. It's also about that level of desaturation. And since we spend 8 hours a night in bed, that can really put a strain on the heart to maintain adequate function. So this is Lisa Lancaster's publication this past year that looked at 50 patients with polysomnograms, 65 years of age, elevated BMI, no surprise. And the obstructive sleep apnea rate was 88%. I mean, it's high in Americans, but not 88%. Jim, you can tell me what it is in general, but I know it's not close to that. 20% were mild, 68% were moderate to severe, and 12% were normal. So the Epworth screening was not a strong screening tool. This is the classic screening tool we use in asking patients questions. Do you snore? Is there cessation of breathing? Neck size? Weight size? You know, all these kind of classic questions that we ask don't correlate well once you have a lung disease. And this probably affects overall survivorship. So when we manage these patients, sleep quality should be a primary therapeutic goal. This is something we can intervene on. Why am I bringing up these comorbidities? Because I can fix this, right? We have treatments for this. We have no proven therapies for IPF yet, but these are things that we can make an impact. And with 39% of patients dying of something else, this is something we can make a difference in. Daytime O2 sat is a strong predictor of nocturnal desaturation, and the spirometric measures are a poor predictor. And a little oxygen at night will go a long way. So the caregiver should observe the patient, recognize it's common, look for frequent awakenings, realize it may lead to arrhythmias, heart attacks, and don't eat before you go to sleep. There's GERD here, and I'm going to show you some more data on that. Now, one of the areas that I think has gotten really fascinating is coronary artery disease in these patients. You see, I've shifted camps. I'm a firm believer that this is not a single organ disease. There are systemic components to this disease, and the data is starting to come out. So this was a study done a number of years ago that actually looked at a bunch of interstitial lung diseases, not just IPF, and took a look at coronary artery disease rates in a retrospective chart analysis, and looked at the odds ratio of patients with these various diseases, non-granulomatous or fibrotic disorders such as IPF, and the granulomatous diseases, versus patients in the same age range without these diseases, and showed an odds ratio in IPF of 2.31. So you were almost 2.5 times more likely to have any coronary artery disease if you had IPF. If you think about coronary artery disease as a fibrotic intimal fibrosis of the vascular bed, you could imagine, or I can fantasize, that the two are interrelated at some more fundamental level than just oxygen deprivation in these patients. And multivessel coronary artery disease, again, in the fibrotic diseases, 4.16. So 4 times more likely to have serious coronary disease of one kind or another. Recent study published last year took a look at IPF and vascular diseases. Again, 920 incident cases. Took a look at the patients as they presented to the system, matched them to controls, and demonstrated what the odds ratio was when they first saw them of acute coronary syndrome was 1.5 times higher. After they were diagnosed with IPF, 3.14 times higher. Angina, 1.84 times higher. Deep vein thrombosis, 1.98, and after diagnosis, 3.39. The vasculature is being affected here somehow. We haven't figured out how, but something's going on. Why am I bringing this up again? This is treatable. There's no reason to withhold a CABG for a patient that can tolerate the surgery. This was a recent one also. This is actually an abstract from ATS that took a look at the survivorship. How does the coronary disease impact survivorship? Well, no surprise, if you got significant coronary disease, your likelihood of survivorship goes down. Guess what? Not everybody dies of their IPF. An 85-year-old is entitled to die of coronary disease. Something we need to keep an eye for. So, if you think about the predictors of disease severity and progression in IPF, we have a bunch, right? I've actually shown you quite a bit. DLCO, certainly as you get below 35%, clearly correlates with worse survivorship. 6-minute walk, if they desaturate less than 88%, again is going to correlate. The distance O2 sat product correlates with risk. FVC correlates, but less reliably. And the reason is that there are a lot of factors that go into that. If the patient smoked for 20 years and has overlying emphysema, the FVC may be falsely elevated relative to where it is. The rate of decline may be more in the vasculature on the DLCO side. We don't know. But the FVC is not as good a correlate as we would like. The decline in FVC over time is a good correlate. Pulmonary hypertension clearly associated with a higher mortality. Dyspnea score, I showed you the evidence for that. And obviously a respiratory event or hospitalization correlates. I think some emerging markers, the high BNP ratio, serum albumin as an overall marker of disease state, elevated surfactant protein A, elevated peripheral fibrocytes. I didn't show you the data for that. But one of the philosophies of this disease is that there's this supercell called the fibrocyte from the bone marrow that goes to the lung and is supposed to regulate things, and it is much, much higher in patients who undergo exacerbations. Abnormal heart rate recovery after 6-minute walk. So how should you monitor these patients? How can we best see what's going on? Well, I can tell you what we do in our clinic. Patients get spirometry, diffusing capacity, and a 6-minute walk every 3 to 6 months. Quality of life questionnaires to help assess how their shortness of breath is doing. We take a look at their O2 sat with every visit. High resolution CT scans, I probably don't do more than once a year, and even at that probably less, because to see changes on the CT scan is going to eventually be a good biomarker. Those 128 scanners are making it possible, but all of the data we have up until now has made that kind of limited in terms of being able to appreciate the changes. And then monitoring those comorbidities. That becomes very important.